Okay.
So I don't forget. That's the first hurdle.
It's like now that you started recording, we all got really quiet.
All right. Hello, everyone, and welcome to Partnerships and Impact with a Values-Based Approach. I'm Mary Gaughan with FSG, and I'll be serving as the staff liaison for today's session. I will be working behind the scenes to support the session speakers and you as attendees in today's virtual session. As we get started, we want to first take a moment to recognize the land that we are on. We would like to acknowledge that this virtual session is presented and recorded on the traditional land of the Massachusetts, Wampanoag, Wichita, Comanche, Caddo, Apache, and Cherokee people, past and present. We honor with gratitude the land itself and the people of these indigenous communities. Before I turn it over to our speakers to kick off the session, I did want to make a few other brief announcements to orient you to today's presentation. All attendees are automatically muted upon entry to the session. Unless you are speaking, please stay muted so we can minimize background noise. If you would like to mute, unmute, start and stop video, please use the icons in your Zoom meeting toolbar in the bottom left corner. You can type your questions and comments in the chat box, which can be found by clicking the chat button in the toolbar at the bottom of the screen. There are additional reactions you can use by clicking participants in the toolbar. In addition, this session is being recorded, and we will make the recording available 1 to 2 weeks after the convening, along with the recordings of other sessions. Finally, all session slides can be found in the online event guide under this session in the agenda. And I will now turn it over to Trey Cockrell to begin our session. Thank you again.
Thanks, Mary. Good morning, everybody, and thank you so much for joining us. I hope you're all doing well. I know it's unprecedented times, and we're probably even getting tired of hearing about it being unprecedented times. We had a call with our Chief Executive Officer yesterday, and he talked about some of the fatigue that's setting in, and just from the daily routine that's kind of happening every day with everybody. So I hope you're all able to get some reprieve from that, and that you're doing well in isolation or wherever you are, and hopefully getting back to a new normal, or getting to a new normal. We're really excited today to be part of this presentation, to be part of FSG and the Collective Impact Forum. There's a few of us who are going to talk today, so you're not going to just hear my boring voice all day, but you get to hear the exciting voices of a couple of my colleagues as well. So Mary, if you'll go to slide 2, you can see who we are. Again, I'm Trey Cockrell. I work with Humana. I've been with the company for a few years now, and had a chance to do a number of different things across a number of different parts of our organization. One of those cool things is working with the University of Houston and with our partner in the Patient Care Intervention Center. And so I'm really proud to have with us today Kalal Mahata, who is the co-founder and CEO of the Patient Care Intervention Center. And he's going to talk a bit about what their platform and model looks like. And then also very proud to be here with Donna Stelzig. Donna is a visiting assistant professor in the University of Houston Honors College, as well as the College of Medicine. And she's the director of the Community Health Worker Training Center. And she's going to talk today about some of the work we've done in this three business collaboration around community health workers and some of the impact we're seeing from that work. So we'll go to the next slide, Mary. Here's what we're going to try to accomplish today, and we want to really talk about this multi-sector partnership and what we've seen be effective here. We want to talk about how we've leveraged community, academia, and business all together in kind of a different way. And this is something that's a little bit new for us as a company, and I'll talk more about that in a minute. but I think it's also a little bit new for others as well as we're getting more into this collective impact kind of work. Secondly, we want you to understand more about the Patient Care Intervention Center's care coordination model. And Kalal and his team have built this fantastic platform that we're leveraging and that we think does a fantastic way of really changing how stakeholders engage and how we address social determinants of health and health-related social needs, and focusing on values, goals, and strengths. And that's an important part, and maybe one of the things that attracted you to this session around values-based care. So at Humana, we focus on value-based care, which is really driving quality and value instead of volume. But Kalal and his team have taken this and really kind of pivoted it, and we were really attracted to that, to focus on values and really what's important to people. So Mary, if we go to the next slide. This is the outline of what we're going to take you through today. So I'm going to present first and just talk a little bit about what we do at Humana and why this is important to us and how we got into the population health space in some of our multi-sector partnerships. And then I'll kind of touch a little bit on the community health worker test and learn and some of the work we've done there. And then you'll see we'll move into Kalal's presentation around PCIC and what they do. And then Donna's going to talk about the CHW initiative at the University of Houston. We'll get into a little bit of outcomes, and then we'll summarize and close it out. And at that time, certainly take questions and answers. As Mary mentioned earlier, if you have questions to type into the chat, our colleague Jess Dobbins is also on this call as well. And Dr. Dobbins will monitor that chat. And if there are things that will help us interrupt on a brief basis, she'll do that. Otherwise, she'll kind of capture some questions for the end and help us moderate that a little bit. So Mary, if you'll flip to slide 5. We're going to start with some polling questions. This won't be too interactive, but we really just wanted to see who all's on the phone with us. And then talk a little bit about your experience in this kind of work. So just to get a baseline, I'll let you all understand who's on the call with us. So you should see the poll now, and we'll keep it open for a few minutes just to see what kind of sectors you're in. So a lot of public nonprofit representation. We're up to about 75% of people weighing in. I wonder if Jess is that 1% of private for-profit who weighed in there, because I did not vote. So you can get a feeling for the folks that are here. Obviously some folks from government, somebody else from the other. If you want to let us know in the chat what area you're from, that would be cool to see. So here you can see the 80% of you, or 79% in the public nonprofit space, and then 7% from government, or 16% from government, and then a little bit from other spots. So let's go on to the next polling question. Okay, how much experience do you have with public-private partnerships?
Trey, it looks like that nonprofit 1% was from the credit union. Tara Hill has joined us from the credit union.
Very cool. So it looks like about 2/3 of you have weighed in, and 3/4 of you have done some of this work before, public-private. But most people are in that bucket. A few, it's second nature. You've done this for a while, and then a few more are completely new. So hopefully we'll be able to illuminate a little bit more about this kind of public-private partnership. All right, just a couple more of these. Again, hopefully you can get a feel for who all's on the call with you. This is just really to talk about community health workers and get your thoughts on how essential they are into improving population health. I'm guessing Donna is clicking over and over and over on the strongly agree button. If she could vote multiple times, she would. So it looks like as we get about 3/4 of you chiming in here, a little more than that, I guess everyone agrees, some more strongly than others. You can see here that 85%, 84% strongly agree, another 12 somewhat agree, and then 5% agree. And we wanted to put this out there because it is kind of been the focus, and it's really what we're going to talk about. The impact of the work we're doing is situated around community health workers. So We've embarked on this test and learn with the University of Houston, and we really want to see how well this can help us improve population health. So next question, Mary. I think this is the last one. A connected whole person ecosystem can help improve health outcomes. So as these results come in, almost unilaterally strongly agree, a couple of somewhat agrees and agrees, but in general, I think everybody at least agrees to some degree that a connected whole person ecosystem really does help improve health outcomes. And we ask this question because this is what Kalal does. This is his business day in, day out. And we are starting really to explore more broadly in the work we do at Humana, how this connected whole person ecosystem can help improve health outcomes. So next slide, Mary. I think that was the last polling question. I think the next one is the cover slide for my presentation. And we'll just get rolling. I'm going to minimize this polling box. Okay. Sorry about that. All right, so the three things I want to touch base on, you can see on the screen. The first is around our bold goal, and I'll explain what that is in a second, and then touch a little bit on the two other topics that I've mentioned earlier around population health and the community health worker initiative. So if you go to the next slide. In 2015, Humana set a bold goal, and we went about improving population health, and we wanted to do that in the communities we serve. And the goal then was 20% by 2020, and we've added and beyond since we're now in 2020. And we do this because we really want to make it easier for people to achieve their best health. So started this in 2014. Back then, I'm sure many of you were steeped in social determinants. Anybody from public health, in the social work field, probably really had a good understanding of social determinants and how those are impacting health. But I'll be candid, at Humana, we weren't. We were far more interested in the transactional basis of the provider and patient or member relationship, claims processing company largely, and more financial transaction. But we really started to understand more years ago about our members and about patients that we work with. And we know now that we keep those patients in our business for about 9 years on average. So with patients around that long, we really wanted to understand how we could have a different kind of impact on their health and not just be there as a health insurer, but be there for a company that makes them surprised at some of the things we do for them and really invest in them in different kinds of ways. So the bold goal really ushered in this new era for us around population health. And so we set this goal, and since then have really pursued it relentlessly. And I was fortunate back in 2014 to work with our chief operating officer and actually start the bold goal work. And we saw it go from one community back then in San Antonio, are now up to 16 communities across the country. And we're seeing some different results across those communities. And you can actually look online. We have a population health website. If you go to humana.com/population health, you can see our annual bold goal progress report out there, and it will show you some of the results we've seen in different communities around the work we do. We measure the bold goal using the CDC's Healthy Days measure. It's a decades-old measure that really hasn't changed much across those decades, but it's one we think is appropriate in helping us understand how many physical and mental healthy days someone has in a month, and being able to take interventions and then track how we progress and improve those healthy days. And again, in not every instance, we haven't been successful in every instance. Every community has not improved healthy days. And we know that there are a lot of things that impact healthy days beyond just the interventions that we have. We've seen in the past, hurricanes in Florida and in Texas. Severe rain in Houston, for example, has caused some issues. The wildfires, just things going on with our country, have impacts on healthy days. So a lot of times it can be 2 steps forward and 3 steps back, or 1 step back. But in general, we still think this is the right goal to pursue and the right measure. And if you'll switch to the next slide, we've been on this journey for some time now, and it's really about working toward a healthier future. And it's absolutely a multi-pronged approach. And you can see from the slide, I'm not going to read it to you, but looking around the 4 different components of how we approach this. About 12 years ago or so, we started as a company on a perfect service journey and really became more of a perfect experience journey. And how do we create a better experience for our members, our customers, and for our providers. And we committed a ton of resources to improving that consumer experience and really also working very hard at improving relationships with providers, especially those physicians who are really dedicated to delivering care directly to patients. And so we focused on how do we improve the experience for each one of those constituents, and now really focusing much more on how to improve patient-physician interactions. What can we put in place that helps enable that transaction or enable that relationship to be stronger, to build trust, and to really help those physicians work effectively with new technologies and in value-based arrangements and in more of an integrated care delivery model. So those are the things that have been kind of important to us as we've thought about working with the patients and providers. On a national level, we focused more on influencing policy and legislation that will help us support and improve population health outcomes. But probably more importantly is around working to address social determinants and health-related social needs, bring those into the clinical model and treat them as gaps in care, and really focus on how we can drive population health outcomes with a focus in those areas. So that's focusing on creating those sustainable, strategic community and physician partnerships to improve health outcomes in those 16 communities we're working in and beyond has been really the key focus of this bold goal. So if you'll flip to the next slide. This is a busy slide, but it really demonstrates how we've worked to bring together so many disparate elements into something of an ecosystem to support population health activities. So by drawing on all aspects of the clinical system, from physicians and nurses and social workers and hospitals and urgent care and special needs facilities and grocery partners and community organizations and community leaders, we've created a better understanding of how to treat people holistically and really focus on whole person care. And I'll talk more about that in a minute. But also it's really become what we're referring to as human care and thinking about people in their entirety. And so we're getting away from more of the sick care focus and thinking about things in isolation and seeing how we can leverage partnerships differently and knowing that we can't do this alone. A lot of our bold goal work has been as conveners, as collaborators. Again, we're not the sole resource to help improve population health, but it's truly going to take everybody in this ecosystem and beyond to make a meaningful and lasting difference. So if you go to the next slide, it's those collaborative efforts that we rely on, and we've made some progress, but we've got a long ways to go. One of the collaborations we're particularly proud of is the strategic relationship with the University of Houston. So we're what we think at least somewhat of an industry leader in the population health realm around integrated care delivery, around value-based care, and really improving the quality of care delivery. University of Houston brings a wealth of clinical knowledge as well. Almost half of their academic programs are focused on health at some level, along with really groundbreaking research as a Carnegie designated Tier 1 research institution, thought leadership, and really the clinical education they bring across the university. So the existing colleges of nursing, optometry, pharmacy, and social work, along with other allied health professions, including the Honors College, College of Education, College of Business, and others, are combined with the newly formed College of Medicine, which just received accreditation and will admit their first class in July of 2020, forms this Integrated Health System Sciences Institute. So we're really proud of having this institute that aligns with our mission, aligns with our bold goal, also aligns with that of the College of Medicine, which is to improve the value of healthcare in Houston, in the US, and beyond. And the focus of the university and the College of Medicine in particular is to turn out more primary care providers. We know in the state of Texas, where I sit, where the University of Houston is, we ranked 47th out of 50 relative to primary care docs to citizens. So there's a big need for more primary care physicians, and that's the focus of the College of Medicine, and the focus of the Institute is to support that College of Medicine to churn out primary care physicians, and particularly those who want to work with the underserved population. So a huge focus around community, around research and education to bring these two entities together to form this institute. If you'll flip to the next slide. So as we think about whole person health, I'm sure that some of you have seen slides like this in the past that demonstrates sort of how our spend is out of balance. in this instance, we're saying about 88% of resources go more to sick care, to medical service. And so if you take a look at the left-hand side of this, that's what we spend on what we think makes people healthy versus what actually makes people healthy on the right-hand side of the screen. So a tremendous focus on healthy behaviors, and again, driven through collaboration. We'll do much more than the other things that we focused on in the past around just focusing on medical services or sick care. So we're really flipping the script somewhat. I wouldn't say we've done that entirely, but the degree to which we can allocate more of our dollars, more of our resources to understand and impact the places outside the doctor's office where health really happens. So if you flip to the, Lex, just stay on the slide for a second. I'll just tell a quick story. We have a member, and I'll just call her Janelle, who's got COPD, chronic obstructive pulmonary disease. She's got emphysema, asthma, all kinds of breathing issues associated with being a former smoker. She's not getting better with treatment. She's going to her doctor. She's getting prescriptions that the doctor knows will have a positive impact on her health outcomes, on her breathing, but she's not getting better. So the doctor makes an assumption that Janelle is just medication non-adherent, just not taking her meds, not using her inhaler appropriately, not doing the breathing exercises that he's asked her to do. But as part of our in-home work, we send a pharmacist and a social worker to Janelle's home. They find out that she actually is taking her medication as prescribed. She's doing the breathing treatments, but she also has 3 cats, and she's got an Afghan on the back of her chair, and there's a cat sitting on the back of her chair, and that Afghan is dusty, hasn't been washed in who knows how long, if ever. And she also has a caregiver, her only son, that lives with her in her 1,250 square foot apartment, who's a smoker. So the house is smoky, dusty, full of pet dander. So under those circumstances, it's almost impossible for Janelle to improve her lung function. So again, we'll work on, and once we understand these complicating factors, we'll leverage the pharmacist and nurse and others who go into the home to see if we can have an impact on those conditions, to convince her caregiver not to smoke in the home, to send in a cleaning crew to help clean the apartment, to get a donation for an air purifier to help purify the air in the home to help improve her condition. So those are some of the ways that we are leveraging our model, being around integrated care delivery, but also going into the home and understanding the holistic part of people in their homes and where health really happens. So if you'll flip to the next slide, we know that this takes a village. The collective impact of groups like this one, really along with the support of public-private partnerships, can really help us achieve lasting outcomes that are going to positively impact health-related social needs and overall social determinants. So one of the first collaborators we started working with in our Humana UH relationship was the Patient Care Intervention Center. And they've really helped us take whole person health and collaboration and improving health outcomes to a new level. We were, like I said earlier, frankly blown away by the platform and model that they've developed. And Kalal can talk about their humble beginnings in street medicine. They still do street outreach on a daily basis, work with the homeless population, and work with a lot of other folks in Houston. And then you're going to hear more about how they, along with Dr. Stelzig's collaboration with community health workers, are really creating lasting outcomes. So with that, we'll turn it over to Kalal.
Thank you, Trey. So good morning, everyone. The framework for part 2 of our presentation is looking at Patient Care Intervention Center's 3-step approach to both understand the problem in our community around a siloed-based model of care. We sometimes refer to it as, silos of excellence. But what can we be doing better to integrate these different sectors together at 3 levels? 1 is from the data side, 2 is from the model side, and 3 is from the collaboration side. And how does that apply to the community health worker initiative that our 3 agencies are working on together? So to start off with a little bit about PCIC, our beginnings started in street outreach and providing care specifically for the most vulnerable in our community, looking at individuals who are homeless, and very quickly realizing that focusing on what we want to provide for them is very different from what an individual who's out on the street wants for themselves. And there's a disconnect there. And that led us to to start down the journey in the last decade and a half, focusing on values and goals of an individual and starting care from there rather than what we would want to provide to the individual. So I'm going to start off with a patient story. Mr. J is his name. This is a patient of ours from a while back. And what you see here is this utilization of Mr. J going to different systems across the community. He is someone who was housed and homeless throughout a period of about 20 years and visited the county hospital system about 95 times, was picked up by EMS and dropped off at different hospital systems, was picked up by the jail system. The recovery center provided services to him, as well as being arrested for public intoxication. Mr. J was a chronic inebriate and had a problem with alcohol use and abuse. And that's what put him on the streets. And while each agency was providing services, to Mr. J from their own agency, what we were missing was this broader picture of the cycling, of the utilization across these different sectors. So not only was he using services at these different agencies, but not getting any better, we were also spending about $500,000 in his care across different sectors. And this is just 1 year. And so when you start to multiply this over 20 years of this cycling, you can start to see how that cost is very much disproportionate to the improvement in his quality of life, as well as his ability to engage with the community around him. And this is just one individual in our community in Houston. We know thousands and thousands of such cases, maybe not so much on the outlier or the end of the bell curve, but very much in the spectrum of needs from one paycheck away to being on the streets or having to make the Sophie's choice of, do I get food or do I get medication, or do I worry about my job? And so we see this very much as a community problem that we need to come together as a community to solve. Our current system is very much in this silo-based model that I was referring to, where each sector is providing services to an individual within their own model. So we have the medical sector providing services to an individual, the behavioral health sector providing services, social service agencies, nonprofit agencies, and then in there is also government services, both at the local, state, and federal level. But what is it going to take for us to move that model to one where it is an integrated response to the needs of an individual? How can we be working together across sectors to meet the needs of our clients, so it is one messaging that we are providing? And we do that in 3 ways at PCIC, and this is the basis of the model that PCIC follows. Step 1 is understanding the needs of a community through data. And so this is really an extension of something that was started in the healthcare sector around health information exchanges, but go beyond just the ability to transfer records from one system to another, but really analyze data, not just from the medical system, but integrating it with social, integrating it with behavioral health, and integrating it with governmental agency data together in one ecosystem. This provides the opportunity to both understand the needs of our community by specific areas or specific locations, but also identifies opportunities for intervening with our community members. Just like Mr. J, where would have been the best possible approach for us to engage with him when he was visiting those different agencies, so that the impact of that visit is lasting and actually helps towards behavior change. The second piece in our 3-step process is looking at the model in which we engage. And this is where the values-based model comes in. Rather than starting from who or what's rather than starting from the problems that an individual has. Is the individual diabetic? Is he or she obese? That's impacting their quality of life. Can we start at a level of an asset that they have? What are their values? Who or what's important to them? And what would they like to be doing, or their aspirations? And use that as a mechanism to pivot and get to the barriers that's getting in the way of their values to have a much longer lasting impact of both engagement, trust building, and outcomes and quality of life. The third piece of it is, how do we then take that and share it with other providers who are also working with that same individual? There are very, very few times where an individual just needs one service. Most times they're going to be needing services from the social sector, from the medical sector, and possibly the governmental and behavioral health sector. How can we, number one, share that values-based approach across different agencies? And then two is, how can we connect the needs of an individual to the resources that's available in the community, and as close to real time as possible for that warm handoff that we need and for that much needed feedback loop. So our platform is designed around those key three principles that we learned with our work on the field in the last decade and a half. We built 3 modules in our platform that's called the Unified Care Continuum platform. And those 3 tie into the three steps that I just spoke about. So we have our community data exchange, which hosts the data across sectors. We have a community care coordination module, which is the idea of a values-based model of engagement, as well as the ability to share that with others in the community. And then the third piece is our community resource exchange, which is mapping out the needs, the resources available within any given community, and starting to have a more algorithmic approach of matching those needs to the most appropriate resource within the community. So what that looks like today in one community, which is in Houston, is about 500 different agencies that are sharing, whose data is coming into our ecosystem to help with that overlap analysis and the needs analysis that we need to do. That, when we take a deep dive into it, is about 2.5 million individuals and about 25 million encounters that's feeding into the ecosystem, and it constantly is growing. And the really interesting part of it is, you're not analyzing the data in one sector. It's how is the police department influencing the food pantry system, and how is that influencing health? And it's understanding these patterns between different sectors. This slide is showing us a few of those partners and how it looks. And you'll see, behavioral health systems there. You'll see governmental agencies, services providing care to homeless, sector like healthcare for the homeless. You'll see large hospital systems in there, as well as community-based organizations that's part of this ecosystem. Our workflow model, especially when it applies to the community health worker initiative that we've started together, is following these 5 steps as we progress through an intervention. So we start off with that population needs and analysis that's driving a big piece of that intervention, to really understand within a small community or within a certain area of the city, what's the biggest need. Step 2 in our process is in training our care coordinators in a uniform way, which is our community health workers, in this values-based model of work. What is the theory behind it? How does cognitive behavioral therapy informed models of care really make a difference? And we've seen that small pivot to go to values instead of starting off at a problem list changes the engagement from about 40 to about 80% for members that we take on to the intervention. The model itself walks through 4 different areas. One is just understanding who or what's important to the client. And this is in their own words. They may say, my son or daughter is most important to me. Spending quality time with a child or a parent is what's most important to me. What would they like to be doing, or their aspirations, and then what's getting in the way of that. I'm unable to take more than 10 or 15 steps before I run out of breath. Well, what can we do about solving that? And so it's pivoting back again each time to that values piece, which both increases the trust building that needs to happen between the provider and the individual, but is also changing the lens in which we look at the problem. Not as we are asking you to fix this, but that we need to do this for you to get to the best self that you want to be, to get to where you want your values to be at. And then part of that conversation is then, what are the resources that we need to connect you to actually be successful? Now, during the intervention with our community health worker initiative, we're tracking our outcomes in a very systematic manner, looking at quality of life improvement using scales like the Healthy Days that Trey spoke about, looking at resources that were connected, but not just resources that we attempted to connect, what was successful, what was not successful. Sometimes learning the barriers or the things that failed works out to be much more valuable than the successes itself. Understanding how we are impacting downstream costs. Are we able to reduce emergency room visits? Are we able to reduce inpatient admissions by having an intervention that's more focused on the social side of it? And then finally, figuring out what that handoff needs to be to a more appropriate agency that can take care of an individual. So most times it might be a primary care home for the individual, or a primary care facility that can continue that engagement with the individual. And throughout this process, what we try and do is to make sure that we're tracking barriers and understanding challenges that clients face, both individually, but also at an aggregated level, to see what changes needs to happen at the policy level, or what changes do we need to make at a systems level for our members to be successful. A few screenshots to give you an idea of how this looks from a platform perspective. This is an example of an overlap analysis. And this is understanding at a very high level or a macro level what the needs of a community are. We start off with one system. In this case, we're looking at a county hospital system who has about 388,000 patients that come through the doors and have about 827,000 emergency room visits. The first visual that you're seeing here is really saying, what does the overlap with other systems look like? This light blue is saying they overlap, they go to just one system, which is the county hospital system. But these dark blues are starting to say, what are other systems that these same individuals are going to, and can we understand their pattern and their needs a little better from the data? We have some demographics here to understand what are the top diagnoses, age groups, and so on. But the next thing we do is overlap it with a second system. And in this case, it's the EMS services. And we see that out of those 388,000 individuals, 84,000 were also picked up by EMS and were driven to different hospitals across the community. So you're already starting to see that patients don't just go to one system. They visit multiple hospital systems for their needs, and not each of them are not seeing the entire picture. It's when we start to bring the data together, we can start to see the broader view. Then we overlap it with a third system. In this case, it's social service agencies, which is through a data set called the Homeless Management Information Systems data set, which is about 80 or 90 different agencies that are reporting their data. And you're seeing about 8,900 were possibly homeless or transitionally housed during that time frame, and had over 1.3 million visits to different social service agencies. And what were the agencies and what are the services they're going for is what we start to analyze here. And in this last example, we're overlapping that same county hospital data of those 388,000 with the food bank system. And you see that 3,200 visited a food pantry, about 17,000 times. And so there we can, right from the data, understand the food insecurity needs of the population without necessarily having to start off with a questionnaire or with an assessment, but the existing utilization data helps paint that picture for us. Coming to the tracking side at the patient level, I put together a few screens to give you the differentiator of this model. So starting off engagement with values, that's actually tracked on the platform. And what you see is that values conversation shows up on the patient record all the time because you want a provider to start there. And so we keep it on that header section. Monica is our patient, fictitious patient here. She said, my son, my dog, and my neighbor Sally are what's most important to me. And so when we have our engagement or our conversations with Monica, we come back to that each time. We then start to define aspirations in the platform for Monica. And so Monica wants to have dinner with Sally on Sundays. She wants to take her pets on regular walks. And then we start to understand what the barriers are that gets in the way, which is the third part of that screen, where you see that she says transportation is a problem for her, and accessing medical care is another area she has problems with. And so we start then creating goals to start to overcome these barriers, and we link them always back to the values that Monica has. As part of that process, on connecting resources, there is an entire section that we focus on in the platform around referrals. All the different referrals that we have to make for Monica is tracked, which you can see here. And if we need to find a new service, we find that directly on our platform to search for a specific need. In this case, we're looking for food near where Monica stays, which is in zip code 77098. And it shows us the different options that we have, and we can submit a referral to that agency directly from the platform. The beautiful part of that referral that goes out, that the community health workers send, is that we send that values-based information along with that referral, so that when they are starting to engage, when the agency, let's say at the food bank, is engaging, they're going to start that conversation with the values discussion. And all of this is done with that consent of the patient, knowing that that's what they want to share with other providers who can provide care. So with that, I'd like to hand this off to Donna, who leads this amazing community health worker initiative through the University of Houston CHW program, and uses the platform as well as the data to track interventions in the community.
Thank you, Kalal. Hello, everybody. I hope everybody's doing well. And we're just gonna wait. We're shifting screens right here. So, but like Kalal said, we have a community health worker model at the University of Houston. And I cannot take all the credit. This was actually developed by Dr. Danielle Price, and who had a very good vision of this model of community health workers. And we met at one of his events and that he put for community health workers, and I attended that event. That's how we got our relationship to work with community health workers. So I have been, and I'm just waiting for the screen. There it goes. So I have been in the public health field and working with community health workers for about 15 years or so. So that tells my age pretty much. So I'm gonna talk to you a little bit about community health workers and the certification that we have specifically here in Texas, the setting roles and challenges that they face here in our state. And some they might expand to other states here in the United States, and how we are trying to overcome those barriers by talking about our other partners in the community and health professionals to build trust in health. And we're going to talk a little bit more about care coordination. So Mary, thank you so much. So I saw a lot of you know about the community health workers and what they do. So I bet you're familiar with all their background. So I'm not going to be spending too much time on that. but there are amazing people. I was one of them, or I am one of them actually, and it's actually a lot of fun to be a community health worker, especially if you are an embedded community member that are also part as of the community health worker network. Next, please. So we have a lot of definitions, and again, I'm glad that all of you are doing this or familiar with community health workers. With one of the background of them is actually started on the model of community health workers, or this workforce. It did not start in the United States. It started abroad, and a lot of the third countries actually they have them as a frontline health workers, and they help a lot with prevention and dissemination of a lot of interventions in health. And of course, here in the United States, it was not until 2010 actually that the Bureau of Labor Statistics actually provided or assigned an occupational code for this workforce. So we're a little behind. That means just over a decade that we have a code for them. So we have to do a little bit more about that. And as you see, there are really your people that actually get to reach out to community members that we cannot get to some of those communities. They have already a trusted relationship with them, and that's why they're so valuable. So with this, we are going to see how they build capacity, and they can actually adapt so easily and take up a lot of new roles. And actually in the health field, it's very difficult profession to be part of, and they face those challenges as well. Next slide, please. So there has been a lot of studies, and when they saw a lot of the presence here in the United States and how they have been changing and have been doing remarkable shifting of tasks from other professions that they can actually assist and help with behavior change. Because after all, like we said, like we read in a previous slide for the definition, they actually help with health promotion. They help with taking roles of informal counseling and so many other roles. So there has been proven research that they actually help in the health workforce, and they are part of the health workforce. Next slide, please. So again, the key functions of the community health workers, and this is important for us to remember when we talk about a little bit forward regarding the role that they'll be taking or they're taking in care coordination. They do have already established relationships. They are the bridge actually from the community to our complex healthcare system. It's very overwhelming. And once you heard as a patient, if you hear the that you've been diagnosed with cancer, then the rest we cannot hear anything else. So they are the community health workers can help dissipate this overwhelming of a lot of chronic diseases that we the overwhelming feeling that we have when we have already chronic diseases and also other diseases and non-communicable diseases as well. So they provide health education at a level that people can understand, and they have actually, they can relate to what is going on and why they're not moving forward and getting healthier. So they're very, they know about that because they're culturally humble. And they know about that because they belong to that same community. So they know how to communicate, and because of that, they can relate and advocate a lot better than any of us could for those members in our communities. So they address not only the disease, but just like Claude mentioned, we start, or the model that we have is establish first the identification of their values. So we can see and develop a plan that is centered on their needs and values and where they want to go and where they want to end. So not only they are there for the community, they're also for other organizations. So they build community capacity with their own communities, establishing a relationship, a cross-collaboration relationship at all levels, which is fantastic. Next, please. So here in Texas, and this is something that we have been working a lot during so many years. I'm one of the first instructors for the program or the certification here in Texas. And this is, it was implemented again not long ago. And we have, it was back in 2001. And back then we were, of course, praying that the certification will allow community health workers to be reimbursed for their services. So unfortunately, the waivers and the Medicare expansion didn't pass here in Texas. So, but it was a very good outcome because they continue to have this certification. Next, please.
Donna, real quick, we got a question. You know, you were talking about the opportunity for Medicare reimbursement. When that doesn't happen, who pays the salary? How are CHWs compensated?
Excellent. And I'm gonna get a little bit ahead because we have that answer, but I'm gonna answer there. There's a lot of other venues, but the most important one is that is very little funding for the community health workers. Unfortunately, because we as an employers, we haven't seen the impact that they can bring to the overall population. There's still a lot of work to be done, and that's exactly what we are going to be addressing a little bit further. But usually the CHW who pays for that is whoever gets them employment. So we are working on a model that they can have their own consortium and they can self-pay for the projects. And so other people who have seen the impact that community health workers do can actually fund those projects, those initiatives by community health workers. Great question, and I'm going to explain more about it. And I'm going to explain first of all the certification here in Texas, so you can we can see how this funding works. So in Texas, as I said, we have in the United States, we have the first certification approved in the United States. And we had just very few requirements. You must live in the state of Texas for at least 6 months. That's what established that you live actually in Texas. And you are 16 years old. It used to be 18 up to last year. We changed that, that policy. And then we have to complete core competencies, 8 core competencies that we established, or we agree with the state. And you can complete that as a training. That means you have to complete 160 hours by an approved training center, or do experience for 1,000 cumulative hours in the last 3 years. And of course, the problem is when a person say, oh yes, I'm working as a community health worker and I'm doing this, and that at the time they submit their application, and the state calls the supervisors where they did the 1,000 hours, the supervisor doesn't know anything about community health workers. So that application is denied. So we, with Dr. Daniel Price at the University of Houston, he wanted a training center that actually captures people from the community, that there already are community health workers and they don't know about it. They just need the certification. And of course, they need the professionalization. Next slide, please. So here we have the where they work, and we're going to talk about funding as well here. So the settings, roles, and challenges. Here in Texas and mostly all over the United States and globally, they work in clinics, universities, education centers, health plans or CMOs, hospitals, and sometimes they are consultants as well, and they have various roles. And as I mentioned before, they're very adaptable, and because actually we need more from them than they need from us. So as part of the university or academia, the best models have been when they actually are involved in the research, planning, and design, not just two pair of legs going out to the community to reach out the population that it needs to be recruited. That's not the case. We should change that, actually, and we are advocating for that. So again, the role models, the roles that they displayed or they have played in the past and present. Also, those are there that you can, that we have mentioned, and we have various other roles that they, their researches as well, as I mentioned. They help a lot with how to reach out those populations that they're at risk, and then we need to do something about it. They are great advocates, and because they can identify so easily the inequities in health. Some of the challenges that they face, again, and this is about the funding, and yes, it's a big deterrent to become a CHW. And some of them, believe it or not, they prefer to continue being a volunteer for their community and advocate than have a paid job as a community health workers, because sometimes the titles are not going to be community health workers, sadly, because legal issues, because politics in the organization, you name it. And sadly, that's the problem, that we don't have sustainable funding because of the job title or the classification. Again, employers play a big role on this because they don't know much about these workforce. They don't know much about how can they help and how can they contribute to the entire team. They just think they can be outside remotely working in the field, rather than they can also contribute to the design and implementation stage of any intervention. A lot of other challenges play into account because of the same. So one thing takes to the next. They don't have the support of the employers. The employers, of course, they have different degrees and they're not familiar with this workforce. So they don't take them into account as part of the healthcare system. So leadership, upper leadership for big hospitals or big institutions, they don't know about these health workers, and they don't think they're part of the actual healthcare system that they should. So they always leave them at the very bottom pay grade. So with that, also we face the problem of standardization of training. Again, the state of Texas has approved a lot of training centers, And that was at the very beginning. And we fought a lot to have an standardization, because a lot of people start opening training centers without a background of the workforce, and they just thought about just delivering education, regular education was the case, and regular education for adults was the case, and it was not. And next, please. So the University of Houston implemented or created the Community Health Worker Initiative. And this is again by Dr. Daniel Price. So he envisioned a consortium or network of real community members. They were acting as a community health workers already, and they just needed the tools and the skills to act upon the things that they were doing, and also provide resources for them. So the community health workers, they have already established relationship with their communities. So he wanted to make sure that this model or this initiative was based in trust. In trust, because the solution or the outcomes will be based out of what that specific community needs, not what I, as a researcher scientist, will go to the community and tell them or dictate, this is what you need to do, this is the behavior you need to change, and you're gonna do it because I say so. So he said, no, we have to do a trust between the community. How can we build that again? Because the healthcare right now is broken. There's no trust. So how can we do that? And the key is the community health workers, as they are the bridge between the community and the healthcare. Next, thank you. So we established then partnerships, and again, one of the partnerships was that, and I'm gonna be going a little faster because I think we're running out of time. Partnerships and bringing, closing the gaps, and that they are identified by the community health workers with their community members, and of course, closing those gaps that they are culturally based. And I'm not talking only about language, but all the melting pot that is Houston, that it needs to be different languages, different backgrounds, different ways of thinking, and all that is what a community health worker helps with strengthening that trust. Next, please. So with that, we, like Trey and Kalal mentioned, we started to work in a base with the care coordination. A little bit more on this initiative was to partner with the Patient Care Initiative Center and using their platform. So that brings that we had to train our community health workers on getting all those center patient with their mind in the values. So understanding what they were thinking about, and Mary, if you can just click all of them, thank you. So the care coordination was gonna help to connect those community members with the resources they had available in their local areas. So we can have a goal of healthier status of these patients or participants, and also lower the show-ups to the health, the emergency departments, and more contact with establishing a relationship with the primary care providers. Next, please. So, yes, please. So how can we establish trust? It is, again, is cross-sectional, it's cross-collaboration at all levels, and that means that we have to have community members be involved with all the partners that there or the healthcare system and stakeholders. If we put them all together at the same level, then we will have better outcomes and everybody will be able to trust in that health. So that's how we are working. Those community health workers came from those same underserved, hard to reach population. And believe it or not, you will see some of them there, and they have come to our certification for our training center for our certification, and they're now employed in this initiative. But it was an effort such as one for Trade and Jess and all at Humana, that this was able to come together so we can be all at the same level and reach out to these populations that they needed to be served, so we can lower the inequities that we have in health right now. And I think the next one, if we go to Trade, back to Trade. Thank you so much.
Yeah, thanks, Donna. And I'm gonna whip through these slides pretty quickly, but we do have some outcomes. They're a little more abbreviated than we'd like. We certainly did get interrupted by the pandemic. So Mary, if you'll go to the next slide, you'll see how we're taking Kalal's platform and applying it to this work. You can see we can break down by demographics. We can see who's involved, who's been enrolled by CHWs, what their demographics are, what their duration of the program is. And go to the next slide. Again, more about their gender breakdown, some of the goals they've set, the action steps they've taken, the age distribution. Next slide. And this shows by patient, if you go back to 2018, how they've interacted with the system. The green bars are showing the hospital or clinic utilization. Those gold bars are the social service utilization. And then on the far right, where we started this initiative, are the CHW interventions. So over time, we'll be able to track and see the difference in utilization across these agencies and across clinics, and how we're having an impact. So next slide. We can also track progress toward goals. So you can see the number of goals that have been set, the action steps toward those goals, some of those we can see what's been completed, what's in progress, and what's still kind of pending. Next slide. And then we can do textual analysis to understand where people are focused. So we know that you can see from word clouds, I think most of you are probably familiar with this, but be able to understand where people's focus is. And next slide. So I'm sorry I went through that really quickly, but I wanted to get to your questions. I know there are a couple of questions already out there, and if anybody has others, please type them into the chat. But just to summarize, we really feel like that these kind of partnerships are essential to really establishing a thriving health ecosystem. We know that effective care models are person-centered, they're multidimensional, they include data, they have different models behind them or platforms. We're focused much more now on a closed-loop platform that Kalal provides, so we can get data and information back to providers about patients and understanding how they are interacting with the system. We know that CHWs are essential to helping us build trust, and that they can influence healthcare outcomes by really supporting values and related care coordination activities. And last slide, I think, really speaks to the notion of collective impact. And we've talked about all along that we got to have a number of people and participants to have this shared vision for change, and one that has a common understanding of the problem and really a joint approach to solving it. So that's what we've done in this three agency or three group bit of work that we've done, and we're really excited to kind of get back at it in full when we get CHWs back out there interacting with people and see what the data tells us. So with that, Jess, we'll get into some questions.
Excellent. Thank you all so much. And thanks for the questions and active discussion during the presentation. One of the first questions that we had was back kind of in thinking about multi-sector partnerships. This question is from Joey, and he'd like to hear the opinions of the panelists in terms of what are the biggest incentives for hospital systems with population health initiatives to partner with local nonprofit partners. The second half of that question is essentially, what do we have to offer them? How can we leverage that partnership to begin to form these important public-private partnerships. And also Joey mentions that, not everyone has the capacity of a large academic institution. So talk a little bit about these partnerships with hospital systems and the appropriate incentives that we see.
Yeah, and the incentive side is a little tricky, and I'll certainly let my colleagues weigh in as well. But we were launching our Bold Goal work in Tampa Bay, and the CEO of Tampa General, we're in a conversation with him, and he said, look, my beds are going to be full. I don't need to seek business. There's enough health issues out there that our hospital is going to be full. So we don't have a concern about that. And he said, we are really at a point where we would love to invest more in the community to help improve health outcomes. I think part of it is maybe less incentive and more feeling that civic duty to some extent to say we're part of this community and we need to help improve health outcomes for the community. And I think that getting hospitals and other health systems and health plans, payers like ourselves involved in this, there definitely are broader incentives, because if we can keep people healthier and get their appropriate and proper, really sort of appropriate and timely utilization of the system across all aspects, we're going to see better health outcomes, and that's going to be beneficial to all of us. So maybe not a great answer, but what I think the social service agencies offer individually and collectively are those resources to patients. And we've found this information is a little bit dated, but we found a little not too long ago that a couple of years ago, I should say, that we found that social agencies were saying, gosh, docs don't talk to us, but docs talk to one another. So how do we break down that barrier and start more conversation with docs? And we're finding out now that docs really are more interested in screening for social determinants as long as they have a place to refer people. So being part of that closed loop and being involved with platforms like Kalal's and others that help people really connect those dots, I think is something that's a fantastic connection point for the social agencies. They're big partners. Hope that answers part of the question, Donna, Kalal.
No, that handles a lot of it. Kalal, what are some of your thoughts then about your specific partnerships with hospitals and how those look and feel a little bit different?
Sure. So I think, over the years, as focus has gotten more and more on social determinants of health and the impact that it has, systems, especially hospital systems, have started to realize that it really does take a village for us to get our patients to the level of, the level of health that both they and the individual wants in their life. I think also realizing that a lot of the impact of why somebody's coming to the emergency room or why somebody's being admitted is related to things beyond services that can be provided in the hospital system. It is community building, it is social isolation, it is loneliness is another big factor. These are things that we address and can be addressed much better on the social side. And even if you were to look at it from an ROI perspective, the spend that they can have on helping fix that further upstream is going to help the hospital as well long term. I think incentives are also determined by if this is a safety net system versus a non-safety net systems, but that goes further into kind of the details and nuances of it. But overall, the community the health community has kind of opened up to the idea that we really need to focus on social determinants to have long-term impact.
Great. There was another question about the platform itself. So maybe you could just kind of restate what platform is being used when you answer this next question. So when one of our guests would like to know more about the exact feedback loops for the medical providers after the referrals are made to the social services. So what exactly does this look like? And where Joey is coming from is that the referrals are often made as kind of this intermediate fix, but the social services are often a short-term fix, the food, etc. So how does everyone kind of come together? How might that medical provider receive the information in terms of what is not just referred, but what's actually consumed by the patient?
Sure.
And used?
Sure, and I'll answer that kind of in reverse. You're absolutely right. The fix of a referral is an intermediary short-term kind of patch. It's a Band-Aid. And that's precisely why we go back to that values conversation. So an example on the housing side of things, on street outreach, as in just one example, we see the same set of individuals that we're trying to house now that were housed 2 years back. Why are we back at that point? We're sending referrals for the same individuals again. We see this in services that are provided where you have 50 visits for getting an ID. We're looping, where it's like the cyclic process going over and over again without any impactful outcomes, right? And so, yes, I see the referrals to be an intermediary fix, but I think coupled with the idea of understanding a deeper or having that deeper conversation around values with an individual is where we can really push for behavior change that is going to target, that is going to push it to be more permanent. As to the part, as to part one of the question of the mechanics of how a feedback loop occurs and what is a successful feedback loop, the way we've seen it is, yes, you can have the technology support and the communication support that you named on a technology platform to actually support it. So the text messaging, the phone calls that the system has to automatically make between a sender and a receiver, and that constant reminder to say, hey, this is 3 days out, 3 days since the referral was sent, we haven't closed it, what's going on? That's one part of it. But the other part, I think, is creating dedicated pathways between a sender and a receiver. So if we're working with let's say a large hospital system, we can bucket about 80% of all referral needs within a group of maybe 15 or 20 agencies and 4 or 5 types of referrals. And identifying that as a starting point will start to take care of the majority of the need. Like 80% of it is done by a dedicated handoff between one hospital system and, let's say, the food pantry system. And if you start to build this agency by agency, very quickly, we start to create these dedicated pathways versus having a more generalized approach of, let me just send out an email back from the platform, from one agency to the other, and hope that somebody is going to open it and check it and respond to it. That's one. The second thing is building the idea of, I think referrals needs to have service level agreements. There should be an expectation that when I do send out a referral, I am going to get a response back for it, or I'm going to know that this is not the right place for this individual, or eligibility is a problem and we need to do something else about it. Some of that we're handling through technology, starting to map out not just community resources that's available, which I think is the easier part, even though that in itself is a big challenge, but the eligibility criteria, which is where things get stuck usually. And the fact that programs come online and go offline, like, we're cycling through some of these programs every 6 months or a year. And when you have things like COVID that can really disrupt where patients can go for services, keeping track of these eligibility criteria across agencies and services that are provided is going to be vital. And we do it in a variety of ways. There is a kind of peer-based model that can be used to kind of build the content in the community, in a given community, or you can have a more kind of track, you have a dedicated team that's doing resource verification and community engagement, which is a side of what PCIC does to keep track of these resources that's available and the eligibility criteria for them. So hopefully that answers. It's a very broad question. I mean, it's a great question, but there are a lot of different things we do that needs to come together to actually make a feedback loop effective and successful.
Sure. No, that's good. If we have just a moment, a good closing question from Michelle is around a buy-in for the CHWs. And while, Donna, this might apply directly to you, it might be nice for all the panelists to kind of close with how we as a collective and as a multidisciplinary partnership and as a broader community, how do we start to mitigate, the way that we have often devalued the impact of CHWs. A lot of people look more towards clinical interventions, but don't acknowledge CHW models as, quote, evidence-based. Any thoughts about how we begin to kind of change that paradigm on the whole?
Yes. So one of the things that we established with this community health worker initiative was having the backup of the justification and the proof of evidence. And that's why the platform was wonderful, because we could see, and we added, when I started working with the platform, I asked if we could have some specific measurements that, of course, other people who are outside the network of community health workers, that they're more in management and finances, that they will look at those numbers and they will say, oh, this one really works. So we're working with the platform to add or include some other measurements that was very important, especially for CMOs, and see some return of investment. So it showed actually the work and how the community health workers were tapping on those local resources. There was a question right there, and I was answering to Matt actually about the 211 resource that there is. We do have that in Houston, but I don't know if that works works on the other states or cities. Really, what people want in the community is to see somebody, and sometimes we have to hold them by the hand and sit them with us and do the tap into the source right there and then. And that's why the community health workers are still more reliable rather than a phone call to 211, that some of our most needed members, they will not have so many minutes or enough minutes to make that call, believe it or not. And some, even though they're not charged to against their minutes, that's their perception, and they will end up not calling. So there is a lot of need. Yes.
I would just add one comment to that around the fiscal buy-in and how do you get buy-in for a company like Humana. As we think about transitioning patients from fee-for-service to value, and really think about the transition of the whole system from fee-for-service to value, our value-based care providers want to see their patients much more frequently, and they want to spend more time with them. They're incentivized to keep people healthy, so they really want patients coming in their office. We know that, for example, in some of our clinic areas, we have up to 15% of our patients who are completely disengaged. Providers can't reach them. They do multiple outreaches, phone calls, and a CHW. One of the things we want to test in this is if a CHW knocks on somebody's door, builds the trust that Donna talked about, can they get them to go into the doctor's office and seek treatment and get them to a primary care doc to really evaluate what's going on with them, especially if they have chronic conditions, as we know a lot of folks do. So that can be really helpful to us. And if that demonstrates the value we think it will demonstrate by closing gaps in care, by improving overall health, it's going to show us that the CHWs are not only do we know they're valuable for building trust, but they can actually get patients in to see the doctor and improve health outcomes.
Excellent. Closing thoughts from you, Kalal, in terms of how our collaborative approach might start to improve the perceived value of CHW.
Sure. I think, the way in which we are tracking outcomes and the systematic kind of scientific evidence-based manner is what is going to drive buy-in. I think sometimes, showing, like being the first to show how something works is what it takes. And I'm confident and certain that the collaborative effort that we have put together in understanding how this trust building activity differs and can be closed faster with the CHW model versus our more traditional models of kind of in office or at a clinic facility will actually enable for the outcomes that we're looking for.
All right, we're a little over time, so we'll close it out there. Thank you all for joining us, and thanks for hanging with us a few minutes extra to answer these questions. And Mary, unless you have anything else to say, we'll close it out on our end.
No, thank you, everybody. The recordings will be available, I think, in a week or two. And thank you for attending.
Thank you.
Thank
Bye,
you all.
everyone.
Thanks, everybody. Thanks,
Bye-bye.
Jess. Thanks, Kawal. Thanks, Donna.
Thank you.